Good evening to all. It's indeed my proud privilege to introduce our esteemed chief guest and speaker for the day, Dr. Dhanunjaya Rao Ginjupally. He is a distinguished Parkinson's and movement disorder surgeon at Apollo Hospitals in Jubilee Hills, Hyderabad, India. Dr. Rao holds an MBBS and an MS in general surgery and an MCH in neurosurgery. He is a IFAANS fellow in movement disorders and functional neurosurgery and neuro-oncology from the University of Kentucky College of Medicine, USA. With over a decade of clinical experience, he specializes in the diagnosis and management of complex neurological conditions, including movement disorders, brain and spinal tumors, epilepsy, and advanced neurosurgical interventions. He is particularly known for his expertise in deep brain stimulation, neuromodulation, and minimally invasive approaches for complex brain lesions, a topic I think which he is going to discuss in detail today. Dr. Rao is widely respected for his patient-centric approach, combining clinical excellence with compassion. He places strong emphasis on patient education, empowering individuals to actively participate in their treatment and long-term health management. His commitment to advancing the field is reflected in his recognition as the recipient of the Clinical Trailblazer Award in Clinical Excellence at the Apollo Group. Through his work, he continues to integrate cutting-edge research and precision-driven surgical strategies to improve patient outcomes. Beyond medicine, he is also a gold medalist in the All India National Yoga Championship and a silver medalist in the Andhra Pradesh State Table Tennis Championship, reflecting a well-rounded personality committed to discipline and excellence. Ladies and gentlemen, it is an honor and privilege to have with us today a clinician, researcher, and innovator who's making significant contributions to functional neurosurgery. I now invite Dr. Dhanunjaya Rao Ginjupally to deliver his talk on advances in Asleep Deep Brain Stimulation Surgery, image-guided precision in Parkinson's disease and movement disorders. Over to you, Dr. Rao.
Thank you. That was very much generous. Without wasting my time, I'm going to start the topic on advances in Asleep Deep Brain Stimulation Surgery, image-guided precision in Parkinson's disease and movement disorders. So can you see my screen?
Yes.
Okay. So I don't have any disclosures. All concerns from the patients are being taken, and the videos which I show in the during the presentation are completely the consents are given by the patients. So these are some of the my papers presented at NICE-FANS in an International Parkinson's and Movement Disorder Society. It's a Movement Disorder Society's conference held in Nice, France. And I'm mainly focused on the targets, which targets will be more beneficial for the patients. We have targets for the Parkinson's disease and other movement disorders, but I try to find out different targets from the usual targets. So when I was in Kentucky, I used to work on cortisone inserter. That's a different target for Parkinson's disease. So in 2019, I presented on connectomics at WSSFN, that is World Society of Stereotactic and Functional Neurosurgery, held at Manhattan. So at the time, I used to talk about the connectomics. Now the connectomics has become the more frequent topic presentations in the conferences. And in 2022, WSSFN, which was held at Incheon, Korea, one of my topics were chosen by Craig Von Hahn as Asleep DPS for tumor targeting, mainly the prelemenical fibers, which I told you as like cortisone inserter. And we use fiber tracking and directional leads to get to the target and the good outcomes. So coming to the DBS, deep brain stimulation surgery, we have different indications for a deep brain stimulation surgery. The main 90% of the patients will be the Parkinson's disease, tremor predominant PD, Parkinson's disease. Essential tremor is another major disease which where the deep brain stimulation surgery is indicated. And other few conditions are dystonia, Huntington's chorea, Tourette syndrome, refractory epilepsy, where we do the deep brain stimulation for anterior nucleus of thalamus after doing all the resection surgeries, resection failures. Even the patient is getting some seizures, then we are going to target the anterior nucleus of thalamus. And we can do DBS for refractory tinnitus and also some other psychiatric disorders like obsessive compulsive disorder, refractory depression. And in some other cases, mainly in the Cleveland Clinic, Andrew Machado is mainly doing the DBS for the stroke patients who are in vegetative state. So this is a video of Bob Jampal. He used to have this Parkinson's disease. Can you see the video streaming?
Yeah.
Yes,
can
we
see.
can see it. Yes, thank you.
And he's Muhammad Ali. He's a sports person. He used to have this Parkinson's disease. Because of this condition, his life was very much devastating at the, after his career. And he's Michael J. Fox. Everybody knows about it. He donated, he actually raised billions and billions of dollars for the Parkinson's research. And he's Adolf Hitler used to have this tremor disorder, this Parkinson's disease. So one is a God man, and one is a sports person, another one is an actor, another one is a ruler. So anybody can get Parkinson's disease. And we are, especially in India, we are at a stage of outbursting these Parkinson's patients at a rate of like 200% in the next 5 years. So by 2030, most of the 10% of the patients, what we see regularly in the OPDs, come with the Parkinson's. So here I'm going to show three different movement disorders. In the first video, he's having this high amplitude tremor. And the second video is the very bizarre movements that doesn't have any pattern. These are called dyskinesias. And the third video shows this tremor. So DBS can be done in different ways. Usually over a period of, in 2003, the DBS was approved by the FDA. So at the time, the DBS was started as awake procedures with microelectrode recording. So over a period of 2 decades, slowly the awake procedure has picked up, and the microelectrode recording has picked up, and most of the centers used to do this awake with microelectrode recording. But some centers out of the box, they used to do this awake and asleep again, to make the patient more comfortable. So in the least recent years, in the last 10 years, asleep with microelectrode recording or motor evoked potential or visual evoked potential are used for the to get the good optimization or in the good to reach the target. So some centers do the stage 1 procedure first, and after 14 days, they are going to implant the IPG. But at our center, we do the both stage 1 and stage 1 the same day. So coming to the Asleep Deep Brain Stimulation Surgery, we have stopped doing the awake procedures over a period of last 7 years. So we do only the Asleep Deep Brain Stimulation Surgery because of the recent advances in the imaging. Imaging has become more sophisticated, and we are able to see the targets during the imaging, and we have the intraoperative MRI and intraoperative CT. So that makes our job more easier. So asleep deep brain stimulation surgery is done under complete general anesthesia. We don't awake the patient during the procedure. And why we chose the asleep DBS? It is much faster than the awake procedure, because in awake procedures, people who are having more tremor, dyskinesias, the patient should be on the table for at least 4 to 5 hours with fixed frame. That makes them more uncomfortable, and they cannot tolerate that type of fixing the frame to the head and being in that single position. And we don't give any medication during the procedure. That makes them more uncomfortable. They feel more anxious during the surgery, and when we try to drill the skull there, the sound or that type of procedure makes them more anxious. And during the procedure, the patients might feel pain. And when we place the second lead, most of the patients goes into this tiredness because of the wear of the decreased dopamine levels in the body, and they might not cooperate during the asleep awake DBS during the second lead placement. That's why the 16 to 19% of the lead placements are misplaced during the second lead placement. So people who will be on the table for longer time, they should be calmed. They should drink, or when they get to pee, patients feel very much uncomfortable and they cannot change the position during the procedure. So in asleep DBS, these all can be avoided. So initially we used to do this asleep with microstimulation. So slowly we have reduced this microelectrode recording because during the asleep procedures, microelectrode recording might have some artifacts. So what we did is we used to stimulate the brain with the actual electrode that is called macrostimulation. And at the same time, after the lead placement, the extension and IPG, that the battery is placed at the same time. And we saved a lot of time during this procedure when compared to the awake DBS. So 3 hours of the time can be saved. And this is another factor. This is one of a patient with this fixed brain. This is something like a bird nest. So fixing that frame and being in during the awake procedure, that makes them more uncomfortable. So these type of patients will have more tremor. During the surgery, these tremors cannot be controlled with the medications. So people will have this continuous shaking on the table, and the surgeon goes into anxiety, and a neurologist and the patient also have some anxious during the surgery. So those can be avoided. So challenges during the DBS surgery in the awake portion of the surgery can be avoided, mainly the discomfort, high amplitude tremors, and especially in the children. Children are not cooperative with this type of frame fixation, being in one position, and awake DBS cannot be done in children. So we adopted that procedure, replicating onto the adult. So anxiety levels, pain during the procedure can be reduced. And severe off symptoms, we don't have um, um, any limitations during the severe off symptoms in the asleep DBS. As I told, fatigue is another factor which makes patient more surgeon to not. We have some compromise during the lead placement because of the fatigue. The patient will not be cooperative during the procedure because we wanted to ask continuously the questions, and when we stimulate, we ask the questions and we see the rigidity, bradykinesia, and a tremor going down during the procedure. But patients are not that much active during this fatigue phase, and we cannot test the speech also. And DBS is not a DBS electrode is a chronic stimulation procedure, but here we are seeing the acute effects. So we have a mismatch between the acute stimulation, that is the immediate stimulation, or the chronic stimulation. That's why we chose asleep DBS for a period of years. And the methods we use is 3 Tesla MRI. And in 3 Tesla MRI, we commonly do the fast gray accretion T1 inversion recovery, susceptibility weighted images to locate the targets, and single stage procedure. And we stimulate the electrode and see the side effects. And we commonly use the CR double frame. We also have the ZD frame. And UPDRS scoring is definitely done before the surgery, on and off, and after the surgery to look for the outcomes. This is an animated video with the courtesy of Rajarshi. So this is how we put the battery in the chest, and the extensions are connected onto the electrodes placed over the scalp, and those electrodes goes into the brain, into the desired targets, and it will become continuously stimulating the targets. And we have this different type of programmings where we can adjust the current, pulse width, and frequency so that the patients get more benefit. And each patient is different. Each patient have a different parameters. So each symptom has different parameters. So what does the Parkinson's, how does we get the Parkinson's? By the time the person gets the Parkinson's, 70% of his dopaminergic neurons goes down. And only the 30% remaining will have decreased levels of the dopamine release, and the patient presents with tremor or rigidity or bradykinesia. And also they have these non-motor symptoms like urinary incontinence, hallucinations, anosmia, constipation, behavioral issues, and all those things. But the DBS mainly works on the motor symptoms. When we place the lead onto the neurons or the axonal pathways, it disrupts the desynchronized pathways and it makes more synchronized. So people come usually ask us, I want to wait till symptoms are worse. But when we give the external dopamine like levodopa, cinnamate, some of it goes into the brain, but the desired effect cannot be achieved because when we give the 100 milligrams of the levodopa, the 100 milligrams never goes into the brain. Only 10% of it goes into the brain. And patients, the side effect of the levodopa are the peripheral side effects. They have this more hallucinations, nausea, and the frequent gut irritability and all these things. So some people have some people have more dopamine going into the brain. So they have these type of symptoms like these are called levodopa induced dyskinesias. They cannot have a control on these movements because the irregular distribution of the dopamine goes into the brain and have these dyskinesias. So how do we get into the central part of the brain? We have stereotactic frames. These are the stereotactic frames we use during the procedure. We fix the frame and also fix the localizer and get to the CT, and we take the XYZ coordinates and we reach into the brain with XYZ coordinates under neuro navigation. So over a period of last 6 years, I did 370 cases. So these images are called the fast gray acquisition T1 immersion images, where you can see the defined borders of the globus pallidus internus, globus pallidus externum, putamen, anterior limb of internal capsule. And we build these tracks. These are called diffusion tensor imaging tracks, where we determine the dentorubrothalamic tracks traveling from the dentate nucleus to the red nucleus to the thalamus. So this is how we fix the frame in the OT, and we sometimes use the robot. And during the procedure, the patient will be under complete anesthesia. And the images here, this image is the intraoperative CT, where once we place the leads, we are going to take the intraoperative CT, and we fuse these images with the preoperative planning MRIs. So during the procedure, we use some type of methods. These are called motor evoked potentials, mainly for the patients where we chose the target of subthalamic nucleus. Because when we stimulate more onto the lateral aspect of the subthalamic nucleus, they have these internal capsule effects. That's why we see the effects from the limbs, face, and the chest. And in case of globus pallidus internum, we use the visually evoked potentials because we are going to target the optic tract. The distal contact should be placed at the optic tract. So if the visually evoked potentials, when we stimulate the distal contact and the patients are having good effect on the visually evoked potential, that means that we are in the right target. So this is a real-time neuro navigation where we put the lead into the target, and this is how we see onto the neuro navigation. So coming to the patients, so he used to work in an army. Before the surgery, if you can see him, like he has this typical Parkinson's gait that is called the chasing of gravity. When they walk fast, we feel that they are going to fall, but they don't fall. But it looks like something chasing the gravity. So after the surgery, you can see it. He doesn't have any. Once again, I'm going to play this video. He doesn't have any limitations during the walking, and his walking is very smooth. Turning around is very smooth after the DBS, 1 year after the DBS. So how the scan shows that the leads are placed exactly right into the target on both sides. You can see it on the scans. That white artifact is the lead onto the center that is located exactly in the center of the target where we planned before the surgery. So another patient, if you can see it in the first video, that that's not a still photo, that's a video running. So he's completely froze. It's called a freezing of gait. So 1 year after the surgery, 1 year after the deep brain stimulation surgery, you can see him walking very freely out there without any option. Usually in Parkinson's disease, we see this whenever they come across this any obstacle, any small thing, they have this freezing of gait. Okay. This is another patient. You can see it here. So these are called dyskinesias, levodopa-induced dyskinesias. These dyskinesias make them very uncomfortable. So even during the sleep, before going to sleep, you can see it. You can see the dyskinesias, very severe. So these dyskinesias causes calorie loss and they lose weight. So after the surgery, you can see her, the dyskinesias are completely gone and she regained the weight. Is another patient with a 40-year-old with Parkinson's with the dystonia. You can see his neck completely turned towards the right side and he has this very slow movements of upper limbs. He used to work as software engineer and he has difficulty in typing. 6 months after the surgery, his walking has improved very much. And after 1 year, usually after the surgery, the patients feel very good inside and they consume a lot. Like they have this functional quality of life improved and they go to the gatherings and they don't have any hesitation going to the social gatherings. So is another patient before the surgery. He has very difficult, very tight hands. These are called striatal hands. He was barely able to stretch his fingers and his shoulder. So after the surgery, he has this increased movements in the both upper limbs and lower limbs. So this patient was operated at another center. So his wife came to us that he has very severe anger. He used to fight with the people after the surgery, and he a couple of times he went to police station. He got arrested, and so his wife came to us to do something, and we actually troubleshooted his complete system, and we checked his MRIs, and one of the lead is misplaced into the limbic system. He was operated outside, so we changed that lead from the original position to the actual targeted position. So before the surgery, just before taking to the surgery, you can see his anxious look, left-sided tremor, and 6 months after the changing the lead from the limbic system into subthalamic nucleus, he became very calm and no tremor. So these are Bluetooth devices. So we can control their movements from 50 meters to 100 meters. So when I switch on the programmer, you can see his tremor goes down. Now his anger issues are completely gone. He's he's another patient who got operated at other center. So the leads were placed rightly into the desired targets, but the desired target didn't help him because the chosen target was STN. So even after doing STN bilateral good positioning of the leads, he didn't get good improvement. So what we did is we changed the target from the STN to the globus pallidus symptom. So after changing the repositioning of the leads from the STN to the globus pallidus symptom, you can see his walking has changed, his movement has changed, and now he has regained his quality of life before the Parkinson's. So he's on the patient who's got this severe tremor. He was an accountant. He stopped doing accounting, and he's always accompanied by a caretaker before the DBS. So we did DBS. So these are Bluetooth control devices. Once I increase the current, you can see his walking has improved. The rigidity, bradykinesia disappears. So after 1 year after the DBS, he was dancing at a party. This type of functional quality of life can be improved with deep brain stimulation surgery. So the advantages of the Asleep DBS are during the surgery, we have less CSF loss because the anxiety of the patient can be reduced, and so that the negative pressure developing in the brain can be reduced. So lesser CSF loss, that makes less brain shift, and we have higher chances of hitting the target easily with the less brain shift. So these are some of the post-operative scans. You can see the less pneumocephalus, less air in the brain after the surgery, immediately after surgery. And the mean duration of the surgery can be reduced from the 8 hours to 2 hours, 35 minutes. It's below 3 hours. So less operation theater time, less opening of the brain, faster recovery, and more outcomes, less infection rates. And other advantages of the sleep DBS are the lesser cost, because we are going to reduce the cost of the surgery during the procedure. And also the OR time is reduced. The resources used during the surgery are very less. So the cost of the procedure also can be reduced. And the mean shift at our hospital is 0.7 plus or minus 0.14. It's the best, when compared to the other institutions, other high volume institutions, we have reached their, accuracy. So this is how we check before hitting the target. So this is a phantom-based frame. Before going for the procedure, we always check for the shift, how much shift we are going to get. So we are going to correct before getting into the before actually starting the procedure. So once we get that minimum error, then only we start the procedure. So other advantages of the sleep DBS are lesser fatigue during the procedure, and the speech has better fluency. We have compared between the awake DBS and the sleep DBS. So, but the sleep DBS has got better speech fluency after the surgery. And other advantages of a sleep DBS are lesser hospital stay, because we didn't do awake DBS. The air goes into the brain, and that pneumocephalus air causes more drowsiness. People stay in the ICU for a longer time. Unless until that air goes down, people doesn't have actual regaining the consciousness or coming out of the drowsiness. So that makes people staying in the hospital for less time. So that another factor helps with the lesser cost. And if we place the target into the right target with a minimum error, people definitely will have lesser programming sessions, lesser visit to the hospitals. So we have lesser complication rates. Till today, we didn't do any lead revisions. So whenever we do a procedure, we have these different type of errors: mechanical errors, human errors, merging errors during the procedure, targeting error, inherent errors of the frame. These all errors can be, to some extent, can be controlled during the sleep procedure. So before going for the surgery, we are going to build these tracks. These are called dental-thalamic tracks. This is fiber tracking. These are sensory fibers. These are corticospinal tracks. So before going to the procedure, we are going to simulate how the contacts are going to be on the lead, so that we can rotate the lead and we can do some directionality, so that we have some lateralization of the current and we can prevent some sensory side effects, motor side effects. So this is how we build the segment the red nucleus, substantia nigra. So we use the probabilistic tractography. These are called probabilistic tractography. We don't use any deterministic tractography to get to the target. So coming to the directionality. So whenever in conventional leads, whenever we stipulate the ring lead, the current generated will be around it forms a circle, it forms a sphere. But in case of directionality, when we stimulate the segmented lead, that the contact, one single contact at that place, so the current generated will be like this. It's something like um, a donut. Um, So this helps in achieving the therapeutic window and less side effects. So when we stimulate the different directional contacts, the shape of the current can be determined, or steering can be controlled, and the shape of the current can be controlled so that the volume of tissue activation, what we wanted, can be achieved during the programming. So whenever we misplace the target that we place, um, sometimes the lead might get misplaced, so that the lead located near the important structures which causes side effects can be avoided by stimulating the contact which is away from that important structure like internal capsule. So when you can see that here, this is the red nucleus, this is the STN, and the actual lead is placed here. When we stimulate the contact, the red nucleus will get stimulated and the patient might have this vision problem. So when we use the directionality, if the contact here is stimulated, the STN is stimulated so that we can avoid this red nucleus stimulation. So we have too many montage permutations during surgery, during the program. That is something like finding a black cat in dark minutes. So we spend a lot of time during the programming sessions with the patients to determine the sweet spot, so that the patient will get 90 to 95% of their symptom improvement after surgery. So that's why we use the image guided programming. So coming back to this patient, he met with a road traffic accident. In 2021. He was in ICU for 2 months, and he got discharged. He was in rehabilitation. After 2 years, he developed this tremor. So he came to us to prescribe some medications, but we did a scan, and he is having this inferior olivary nucleus hypertrophic degeneration that causes this tremor. This is called the rubral tremor or Holmes tremor, high amplitude tremor. So they also have this ataxia. So before going for the surgery, we usually the retroprothalamic tracts are stimulated. Because his tremor is on the right side, we stimulated the tract on the left side. So these tracts are are located between the red nucleus and the subthalamic nucleus, that is called cortisone center. It's a high volume, high density area where we can stimulate recruit more number of fibers with lesser current. So immediately after the surgery, you can see his tremor amplitude has gone down. This is how the video shows that the lead is exactly right onto the target, going along the red dot. Okay, so after the surgery, this is called image guided programming. So if you can see it here, the lead is simulated onto the software. When we increase the current, you can see that the sphere has been developed at the ring contact. When we steer the current from lower down contact to the upper contact, that's a dorsal contact, you can see that the shape of the current can be determined with the different parameters, and the tracks are recruited slowly into the um, electrical field. That is called volume of tissue activation. When the tracks are recruited completely into the electrical field, people will have good control of the tremor. You can see that the tracks are recruited into the electrical field. Okay. Then after the surgery, the tremor has completely gone down. No tremor. So on the patient, second patient who has this severe dyskinesias before surgery. These dyskinesia, he is 40 kgs and we gave him 50 milligram of levodopa, even 50 milligram of levodopa, the very low dose. He is having this dancing like movements. So we offered him deep brain stimulation surgery. So we chose the target of globus pallidus internum. So after the surgery, we stimulated the GPI, globus pallidus internum. The middle contacts are activated. You can see that the current is steered towards the upper contacts so that the GPI can be stimulated. So this image is from Michael Okun from the University of Florida. He says that the middle contacts, when we activate the middle contacts, the people will definitely will have dyskinesia suppression and anti-Parkinson's effect. So here, when you see that this is stimulation of the tracts. When I stimulate, you can see that the fibers are getting activated, and these are called pallidofugal fibers. So these pallidofugal fibers, when we stimulate these fibers, the dyskinesia goes down. So with the minimum current, we have to activate more number of fibers. This directionally helps in this getting good optimization after the surgery. This is also called image-guided programming. So after the surgery, you can see the dyskinesias are completely gone. Okay, it's another patient, third patient. You can see the current, we are generating current, and here pallidothalamic fibers are stimulated. That controls the tremor. So when I stimulate, look at his tremor completely gone down. Before the surgery, he was barely able to drink water from glass, barely able to eat. He was not able to hold a spoon. So after image-guided programming, we achieved good optimization within 3 months. And after 5 months, tremor completely gone down. So in initial programming sessions with the help of image-guided programming software, the time has reduced from 4 hours to less than 25 minutes. In same patients, later programming sessions has reduced from 15 minutes to 8 minutes. So this image-guided programming has sustained effects of stimulation even after 1 month. So genericity is less precision, this is a precision-based surgery. When we try to get the precision during the surgery, because precision is the main key factor in achieving the outcomes after the surgery. So what we do is, before going for the surgery, we deconstruct the system, and we follow this every case, then followed by construct the system. So over a period of last 1.5 year, we developed this fast track DBS, that is also called the same day DBS or ambulatory DBS. The patient comes early in the morning and they get discharged in the evening. So we use the worm of the CT, intraoperative CT or MRI, and we are not following any traditional method of shifting the patient from the OR to the CT scan and getting back the patient to the OR and do the surgery. We are doing the intraoperative CT. So this is how we do the imaging and prepare the electrode while starting the skin incision. We reduce the time. And these are the intraoperative CT images. And we fuse, once we place the leads, we fuse those images with the preoperative MRI and check whether we are in the right place. Then we close the skin. So 83 patients were done as a ambulatory DBS. So I'm going to skip this. So this is another software we borrowed it from University of Berlin, Lead DBS. During the procedure, we can measure both microelectrode recording and also the EMG. So visual output potentials, this is how we do the stimulation during the procedure. So we connect it to the programmer and we check on the neuromonitoring, how the VEP is. So when we stimulate the lower contact, the optic tract gets stimulated and we can see the recordings in the neuromonitoring. That means that if the visually output potentials are good, that means we have placed the lead right into the right target. We use P100 to know the accuracy of P100 latency to know the accuracy of the optic tract proximity. EMG recordings to detect the internal capsule effects. This is how we record all the muscles in the upper limbs and lower limbs. So sometimes we use this, if you are going to place the lead near the red nucleus, we are going to check the red nucleus proximity by placing the lead into the conjunctiva, and we check for the eye movements during the surgery, because this is, we are doing under the asleep. Patient will not give any feedback to us. We are going to check with the neuromonitoring. So after the procedure, we always check 2 more times whether we are right in the place or not. And once we feel very comfortable that the leads are placed into the right target, then only we close the skin. So this is another patient with Meeks syndrome. This is called a blepharospasm and anterior pollice of the neck. Before the surgery, she was having very difficulty in drinking, seeing up, not able to lift the neck. So after the surgery, immediately after the surgery, you can see her walking. So her blepharospasm has gone down. So after 1 year, usually the dystonia takes at least 6 months to improve. And even after 1 year, she has good optimization, good sustainability of the effect of DBS. So another international patient from Yemen. So at their home, he was having this bent spine syndrome while walking. So if he takes Sindopa, he has this dyskinesias. So immediately after surgery, and after 1 month. So is another patient. Tremor, bradykinesia, rigidity. Immediately after surgery, you can see his rigidity, bradykinesia is completed. So we try to do 2 DBS per day because we have reduced the time and we have a robust workflow system to do the DBS, 2 DBS a day. Usually high volume centers never attempted to do 2 DBS a day. It's very stressful for them because they do the procedure and awake. You can see this guy has severe tremor, bradykinesia, camptocormia, that is, it's called this change of the posture of the dorsal spine. Very slow walking. Immediately after the surgery, you can see him walking very, very smooth. Another patient, severe dyskinesias immediately after surgery. Dyskinesias has gone down. 8 months post-op, no dyskinesias. So this is very interesting case. Very interesting case. He met with, he was in a bum blast and he has this movement disorder. We tried to diagnose what caused it, but we never determined what actually caused it. So before the surgery, he was barely able to walk. After 6 months post-op, he again rejoined the army. So the military has posted this video on social media, and within 1 hour they got around 2.3 million views. Another patient from UK, NHS, he came to us, but this severe dyskinesias. He was on apomorphine pump. Without apomorphine, he used to have severe rigidity and bradykinesia. With apomorphine pump, look at the dyskinesias. So after the surgery, medical student before the surgery, early in the morning. After the surgery. So if you can see the time, we started at 1:21 and we have started the procedure at noon after 1:21. And you can see it here. Going to just forward it. This is how we do the procedure. These are the stereotactic frames we use during the procedure. Once we place the leads, this is how we place the lead into the brain. We have around like 150 steps in this procedure. Any step goes wrong, the total procedure is going to have a devastating effect after the procedure. So we should not hit any blood vessels. We should not go into the brain stem. So this is how we place the battery into the chest. Here the battery is placed into the right chest wall under the skin. So this all takes around like, we check the impedances during the procedure. After the procedure, how are the impedances? Because once the impedances are good, then only we close the procedure. So I just wanted to show you the time. So it takes around like 60 minutes. So within 1 hour, we are going to finish the procedure. The safety outcomes, average stay in the hospital is 6.3 hours after the surgery. We didn't have any post-operative hemorrhage. One patient came, revisited the hospital with the atrial fibrillation. He preoperatively used to have 40% ejection fraction. And 30-day readmission, that's a patient presented with atrial fibrillation 1. So complications with the hardware infections, early complications like lead fractures, these we didn't see anything. So the take-home message is same-day DBS surgery has at least equivocal safety profile compared with the inpatient DBS. So same-day DBS surgery significantly reduces length of the stay, and compliance to same-day DBS surgery is more. Patient prefers less stay in the hospital. So same-day DBS did not differ in 30-day ED visits or readmissions, infection rates, or total complication rates. So we made a standard procedure to do the same-day DBS in our hospital. So another topic, another important topic. This is one of the paper we published. That is recipient reaction and composition of autologous sural tissue graft into the human brain. This was done at University of Kentucky. There, it is called DBS plus. They place these nerve grafts into the substantia nigra during the DBS procedure. This is how they do it. They cut it into the 1 mm pieces and they place these grafts into the substantia nigra. And many patients have been recruited into this trial. This is called DBS plus. Before the surgery, so 6 months after the surgery, is off medication. So we did some postmortem studies or DAT scans, and we didn't see any decrease in the degeneration on the grafted site on DAT scan. So I'm going to skip these. We did some postmortem studies, and we noted that the grafted site has more number of dopaminergic neurons, multiplication, and decreased degeneration of the neurons. And we took the help of this Granham Lotte from Nobel Institute of Healthy Aging, University of Delhi. So this is animal lab. I'm going to skip this. So I did the first Asleep DBS surgery in India at NIMS in 2023 and first Asleep DBS surgery in 2024. Right? So these are state-run hospitals, high volume centers where they are planning to adopt Asleep DBS. So these are my mentors. Craig Von Hahn from University of Kentucky, Thomas Pittman, he is professor of neurosurgery at Kentucky, and Greg Gerhardt, he is professor at University of Kentucky. Thank you.
Thank you, Dr. Rao. The floor is now open for questions.
Yeah, I have a couple of questions. This is Jyotsna.
Yeah.
What do you think the role of F18 DOPA scans is in your patient management?
Usually many patients are many Parkinson's patients are getting dopa. You're asking about the DAT scan or the just PET
F18 DOPA PET scan.
PET scan. Fluorodopa PET?
Yeah, that we do at our hospital, Apollo.
Yeah. DAT scan. Usually in Parkinson's, we don't determine Parkinson's based on the fluorodopa PET. So that mainly helps, the fluorodopa PET mainly helps in differentiating between the tremor, whether it is because of the Parkinson's or essential tremor. That is the only, it's highly sensitive in that, that area.
Okay. And just one more question. Do you see any role for artificial intelligence in the surgery part or in the future?
Yes, the image-guided programming is comes under the artificial intelligence. We have now in the last 3 months we have implanted 8 cases with adaptive DBS. Adaptive DBS is something like when the DBS system itself captures the beta waves from the patient. Those are called local field potential.
Okay. Thank you. Excellent talk, I thought. Yeah. Thank you.
Yeah, hi, Dr. Dhanunjaya. This is Harshad here from Grand Rapids in Michigan. Excellent talk, really stimulating our deep brains. So this being an audience of nuclear medicine and molecular imaging, on that particular note, I wanted to ask, based on that one case which you showed, that the lead was not correctly placed. So is there any role of molecular imaging like FDG to test if your lead has been correctly placed, rather than waiting for or some sort of an objective verification before the patient starts reporting improvement of symptoms?
Hi, Harshad. I think Dr. Rao got dropped off.
Oh, okay.
We'll just, yeah, I think he just got dropped off. Maybe we could just wait for a minute or so and you could repeat your question.
Sounds good.
Yeah.